I am the viewer.
Good morning and welcome to Psychiatry Grand Rounds. If you are an attending, resident, or medical student who needs to register for CME credit or attendance, the information on the new QR system is posted in the back of the auditorium. If you are a psychology student and need to confirm attendance, you may ask the speaker or myself to sign a paper confirming your attendance. This morning I have the pleasure of introducing Dr. Michelle Duffourc. Dr. Duffourc obtained her bachelor's in chemistry at the University of South Alabama in Mobile. She has a PhD in basic medical sciences and pharmacology from the University of South Alabama College of Medicine. And she was a postdoctoral fellow at the Department of Biochemistry and Molecular Biology at the University of South Alabama College of Medicine. She is an associate professor of biomedical sciences and the director of molecular biology core facility at East Tennessee State University. Please welcome Dr. Duffourc.
Good morning. Thank you all so much for the invitation, and thank you all so much for taking the time out to come and listen to me today. So what I'd like to do to begin today is to introduce you to somebody who's very special. Okay? And this person is Michael. I can show you Michael's picture because he was the subject of a national news story, and so which his family released to the public to help educate everybody about what is particularly going on, in particular with pharmacogenetics. But Michael's story is actually a pretty tragic one. His mother was abusive, and before his first birthday, he and his elder sister were removed from her custody. He was in foster homes for a couple of years, and then when he was 3 years old, he was adopted by a very caring couple. Now, this couple was told at the time of his adoption that he and his elder sister had some developmental delays. But it turned out that their problems were far more severe than that. As time progressed, it became apparent that Michael had fetal alcohol syndrome. Okay? He started showing the tics and the picking consistent with Tourette's syndrome. He had ADHD. He was obsessed with doing things in threes. He would brush his teeth 3 times. He would tie his shoelaces 3 times. So OCD. And well, this was all a concern for the family. As he got a little bit older, by the time he was 5 or 6, he was put on methylphenidate. He was put on clonidine, which makes sense. All right, a little young. But one of the big issues that was going on with Michael is that he was violently moody, by which I mean something might set him off in the morning. No, you may not have your sister's cookies, and he could scream for hours.
May I have your attention, please? Code blue, cath lab 2. Code blue, cath lab 2.
Anybody? All right. So at any rate, something would set him off in the morning. He might wake up that night screaming, okay, still about it. His parents had to take the doors off the hinges to keep him from slamming his sister's fingers shut in it. They had to put plexiglass over the bedroom window because something would set him off and he would take his toys and try to fling them through the window. Okay? It just kept getting worse and worse. One night, or I should say one morning, they found him groaning because he'd gotten up in the middle of the night and he started eating all of the food in the refrigerator and could not stop. So what finally, became the breaking point for his family was that they had taken him to a restaurant and had ordered spaghetti. And he decided that his meatballs were smaller than his siblings. And he started screaming, and then he reached into his plate, he grabbed the spaghetti, he threw it into the air, and there was a ceiling fan. Okay, so while this is something that is like, oh yeah, great slapstick from a movie, right? But can you imagine what it was like, to be the family of this, all right?
So, attention, please. Cancel code blue.
Good thing. All right.
Cancel code blue.
So what you could see is he kept screaming and screaming. The parents called their psychiatrist. The psychiatrist could hear him screaming in the background and basically decided, we've talked about this before, let's go ahead and try him on some fluoxetine, okay, Prozac. And Michael was a very tiny child, okay, physically small. And so they started him off on 5 milligrams a day, okay. Well, just like you might have seen, at first it seemed to help, and then as time went on, not so much. So they increased his dose, 10 milligrams. Got better, things started going worse, 30 milligrams, 60 milligrams, 80 milligrams, 100 milligrams. Would y'all put me, okay? Fine, I weigh 150 pounds on 100 milligrams of fluoxetine a day, Probably not. Would you put a little 40-pound kid on this? All right. Then what we started to see were some issues. Like he was running around playing, all of a sudden he sat down, Dad, I'm so dizzy I can't stand up. He started becoming very nauseated. Okay? Warning sign there, right? If you're on an SSRI, you're becoming nauseated, yeah? And so they were starting to think, well, maybe something going on. And as time went on, he started showing a little bit more incoordination. And then one day in the winter, he was 9 years old. It was snowing. The weather was horrible. The roads were getting worse by the minute. The parents were awakened by a sound of like a thumping sound coming from his room, and he was having a seizure, in his bedroom, which stopped very quickly. So they called a psychiatrist who said, okay, just keep an eye on him, monitor him closely instead of trying to drive through this. And then, so a few hours later, he started having more seizures. And this time they didn't stop. And they called the ambulance. And the ambulance brought him to the hospital. He had stopped breathing, where he was pronounced dead. All right, so this is horrible, right? You don't need any more horrible than this, but it gets worse. Because at autopsy, they found that his tissue concentrations of fluoxetine and its primary metabolite, norfluoxetine, were significantly elevated. So, what did the authorities think was going on, my friends? They thought the parents had potentially killed him, all right? And so the parents were charged with murder, and the custody of their other 2 children were taken away from them. All right. So why am I telling you this? We're doing a talk today on pharmacogenetics. So by the end of today, actually in 3/4 of the time, you should be able to tell me what genetic diagnosis would be consistent with Michael's case, all right? So let's think about this, As clinicians, you face a lot of challenges in your practice, correct? Particularly, I know you deal with a lot of patients who have depression. And depending on who you read, approximately 50% of the patients who have depression are not going to respond to the first drug that you put them on, right? Give or take. So that's an issue right there. The other problems that you're going to have are adverse effects, many of which your patients are going to find to be intolerable, the sexual dysfunction and so forth, depending on which agent that you're looking at. And so about a third of the patients are going to go ahead and discontinue their medication just because they find the adverse effects to be intolerable. So now we're having a pretty large percent of patients that are not either responding or not wanting to take their medicine. But you can take this further. This is from an older study. Adverse drug reactions, depending on some of the literature, are actually a leading cause of death in this country. One study that I read stated that about 100,000 people had died the previous year in hospitals due to adverse drug reactions. And this led to a lot of changes going on in hospital settings to help promote more drug safety. Now, other people argued that this study that had been released by the American Medical Association may be a little bit excessive in their prediction, but still, and they were coming up with maybe 40,000, but no matter how you slice it, imagine a city the size of Johnson City, that kind of population, 60,000 people maybe, disappearing every year, courtesy of adverse drug reactions affiliated with hospitals. And that's not counting accidental overdoses. This is a huge problem. Now, there are lots of contributors to adverse drug reactions, right? And you never know exactly why a patient may have one and why they may not. Some patients may be mixing drugs that they should not be mixing and so forth. But what we're going to see today is one potential contributor is going to be a patient's pharmacogenetics. Now, and of course, getting into one of our other things, You know, a lot of your patients, okay, you're psychiatrists. Do your patients necessarily want to be adherent with their meds? Okay, a lot of patients, I see that, no. All right, so let's think about this. You have a job, you have a patient, and you need to be able to pick some kind of treatment for them, okay? So what are you going to start to take into consideration? All right, first thing, what is their illness? You know, do they have schizophrenia? Do they have bipolar? Are they depressed? Okay, is a patient having dementia, you know, related to Alzheimer's or something? Okay, primary thing that you're going to consider. You know, other things, are they going to adhere? What kind of adverse effects can the patient tolerate these particular agents? You know, can they afford it? So you take all of these things into consideration, you think about it, and then you write a prescription, you know, for some kind of pharmacologic therapy, okay, in addition to psychological therapy too. So what I'm really trying to say today is where we're starting to go in therapy is that we still need to take all of these factors into consideration, but now what we also need to start taking into consideration are the patient's genetics. And so we'll take this, and then hopefully what we can do is start to develop a therapeutic system that actually takes the patient's individual biochemistry and physiology into consideration. So let's talk a little bit about this. What is pharmacogenetics? Well, really, all we're looking at is that the history of it goes back into the 1950s, where people were noticing, remember this from medical school? Okay, if you went to Quillen, I know you know this because I know Dr. Furslew covered it, right? Okay, that we started to see patients who were put on isoniazid or succinylcholine could develop adverse drug reactions. So perhaps the patient had a different isoform of butyrylcholinesterase and they were not breaking down their succinylcholine as much. Perhaps they had a genetic difference in their N-acetyltransferase, so they could not metabolize their isoniazid as rapidly. And people started noticing this, just here's the patient and here's how they're responding adversely to a particular drug. Now, so really what our later studies show is that all we're talking about with pharmacogenetics is that we're going to use this information about the person's specific genome to help us dictate our pharmacologic therapy for them, okay? What will work best? Now, do physicians feel that this actually has the potential to help them? Well, this is a paper that came out about 3 years ago, and I'll try to point out some of the biggest things, okay? The end of the story is that, as I have here, psychiatrists in these surveys really felt that pharmacogenetics has the potential to improve patient care. So if we start to look at it, and I'll walk over to the other one a little bit, when questioned, do you think that having genetic data would help you and your patient make better decisions about their care? 100% of the physicians said, yeah, they thought it would. Okay? Would you act on specific data to help you indicate your care? About 95% of the physicians questioned also said that they would. Now, where you start to see less enthusiasm was psychiatrists were not as inclined to suggest that patients go to a direct-to-consumer genotyping. And that's a really good thing, and at the end of this talk, I'm going to show you why. All right, so the potential is here, okay? And what it means is that if we start to use more and more genetic information to help drive our therapy, there may become more potential for collaborations between psychiatrists and genetic counselors in the future. All right, so let's talk about our general categories. Okay, when we start to think about pharmacogenetics, it tends to fall into three flavors. Okay, the first one is pharmacodynamic. Okay, this is where we're looking at genetic changes that will impact how the drug reacts with its receptor. So a classic example of that might be cystic fibrosis, right? So remember what's going on in cystic fibrosis. You have the deletion of a phenylalanine in the CFTR protein, all right? Now, and that happens in about 95% of the patients. Well, about 5% of the patients actually have a swapping of one amino acid for another. That 5% of the patients can actually respond to a drug called ivacaftor. So this is a classic example of using pharmacodynamics, a pharmacodynamic parameter affecting pharmacogenetics. Make sense? All right, we can see this with like warfarin. For your colleagues who are in infectious disease, okay, if a patient comes in and they are infected with HIV, that patient's strain of HIV is genotyped. And they do an analysis to determine which drugs that patient will respond to. Okay, so very classically used there. Now, okay, that's great, but what about for y'all? The problem for y'all is that in psychiatry, there are some potential markers. You know, for example, serotonin reuptake transporter. Okay, the serotonin 2A receptor seems to have some correlation between genetic changes and perhaps some disease. Okay, but there's really nothing tight about it. Okay, and a lot of the data is just really not consistent. And think about what's going on. Okay, I talked about cystic fibrosis. Okay, that's a monogenic genetic disorder, right? Is that the case in any of your psychiatric disorders, schizophrenia? No. So here what you're seeing is that psychiatric diseases, you know, genes which help predispose patients to them, you know, there seems to be a lot of them, and each individual one contributes a little bit on its own. And then you're going to have the interplay with the environment. So we don't have a really clean approach to using pharmacodynamic parameters in helping to manage your patients in psychiatry. So let's switch over to our next one, pharmacogenetic. Remember pharmacogenetics, friends? Okay, if pharmacodynamics is how the drugs act on us, pharmacogenetics are how we act, our bodies act on the drugs. So metabolism and so forth. Now, so let's start talking about this. There are a number of drug metabolizing genes in the body. Okay, we've talked about, I mentioned N-acetyltransferase, for example. But hands down, our big ones in the family are Cytochrome P450s. So let's think about this. There are a lot of Cytochrome P450s. Your biochemistry class wailed on it. Your pharmacology class wailed on this, right? And so let's think about it. Okay? There are at least 58 genes encoding cytochrome P450s. And when you start to put them together according to homology, they fall into the three major families. So when you look at the drug names, you see like CYP1, CYP2, CYP3, each of your three major families. And then each individual family has different members of it, you know, which again, they try to lump together according to homology. So you might have like cytochrome P450 like 2C or 2D and so forth. Okay? And where the last number is the specific member of the family. All right, so there are a lot of them. They're expressed all over the body. They're expressed very, very heavily in the kidney where they're going to do their job protecting you from xenobiotics, those things that you've been eating, okay? Things that you have been ingesting somehow. That's great. But even that is still not enough, because you'll see that these agents will have multiple variants of them. So I have on here, like our cytochrome P450, here's 2D6. There are at least 100 reported variations of it, okay? Huge amount of variation. So if we sat here and started genotyping all of us, we'd probably find almost as many different alleles expressed in combination there are as they are of each individual one of us. All right? So let's go ahead and take this on. Okay? Now let's think about this. When we start to talk about all these different cytochrome P450s, you know, 58 of them, some are more important than others. Okay? The ones that are going to be really important are going to be cytochrome P450 3A4. Okay, 3A4 is important because it is capable of metabolizing, or has primary responsibility for metabolizing almost half of the drugs on the market. All right? Now, but another really important one, and for y'all, okay, hint, hint, subtle, subtle, to borrow Dr. Furslow's saying, is going to be 2d6. It has responsibility, primary responsibility for metabolizing about a quarter of all of the drugs that are out there, okay? So very important one. The one that I just told you has at least 100 different variants, okay? Others that tend to be important are going to be 2C9 and 2C19. Now, let's think about this. If we start to add up all of these numbers, fraction of drug metabolism, okay, it adds up to over 100. So here's my take-home point. While one drug might be primarily metabolized by one of these enzymes, okay? One drug might be primarily metabolized by 3A4, or it might be primarily metabolized by 2D6. It doesn't mean that that's the only enzyme. Other enzymes might also be able to metabolize it too, just not as efficiently, all right? It's going to be important when we go back to talking about Michael. And so one of the reasons why I tried to point out 3A4, 2D6, 2C9 is because they carry the majority of the responsibility going on. So let's talk more about 2D6, that really highly polymorphic one. So what are some of the drugs that it metabolizes? Well, I have a list, and you may see some that you recognize, right? I mean, tricyclics, all of them, every last one. Almost all of the SSRIs with the exception of citalopram, all right? Your SNRIs, your antipsychotics, okay? Importantly, opioids. And a lot of the opioids that you are using, my friends, are prodrugs. So that's going to have an important ramification in just a couple of slides here. All right, so what that means, my friends, is since this enzyme has so much genetic variation from individual to individual, and so many of the drugs that you use are metabolized by this, is there any surprise to you that how patient A versus patient B versus patient Z handle these drugs might be different? All right, so let's dig in with 2D6 a little bit more, since it's so important. What I'm just trying to show you here is that if we have a piece of DNA that has on it the gene encoding 2D6, right? It goes ahead, it gets translated into a messenger RNA, which then gets translated into the functional 2D6 enzyme. Cool? Now, why am I bringing this up? This particular allelic form, the fully functional one, is termed star 1. So if you're looking at something describing 2D6 alleles and it's CYP 2D6 star 1, it's saying the patient has that particular gene, all right? But let's take a look at this a little bit more. Not everybody has this one, okay? Or at least not everybody has that one on both chromosomes. Some patients may have something called the star 5 deleted gene, okay? If the patient has star 5, it means that the gene is just completely deleted from their genome. And if there's no gene, there's no messenger RNA, there's no protein. The flip side of this is that they may have an XN, okay, times N. So in this case, I'm showing you, okay, you've got your normal wild type star 1 allele, but if you have XN, you will have multiple copies of it. And by multiple copies, it can go all the way up to 13 copies. So is this patient going to have the same amount of metabolizing power, less metabolizing power, or more? More, a lot more. All right, so you've got your two extremes, which means, we've got to do Goldilocks here, okay? One is too much, one is too little. Hopefully star 1 is just right. But you can also have, of those 100 different alleles, something like what I'm trying to show you here, star 4, in which case it has a mutation where you have not full activity, but reduced. And reduced can be anywhere from almost full activity to almost none at all. Got it? All right. So why do you care? No, Dr. Duffourc, you're the molecular biology core facility director. You care, we don't. Oh, but you do. All right, let me tell you why. Because when you sit there and you start to look at your patient's genotype, it's going to be tightly linked to their phenotype. So if you're doing genetic testing and the patient has like the star 1 and the star 1 XN genotype, okay, where they have more than the normal number, okay, This results in what we call the ultra-rapid metabolizer phenotype. Okay? They're faster than the average person. If the patient has just 2 copies of star 1, they're an extensive metabolizer. If they have some variation, okay, where they have at least 1 where you have reduced activity, but you have at least 2 alleles that have some activity, some variation of that, you get an intermediate metabolizer phenotype. And then you can start getting into, like your star 5s, poor metabolizer phenotypes. Now, again, what does this all mean? Let's think about this. We've got our ultra-rapid metabolizers, our extensive and intermediate metabolizers, and our poor metabolizers. If you've got a patient who's an ultra-rapid metabolizer, what may be going on with them is that they're just metabolizing the drug you're putting them on too fast. Okay? So, on the flip side, if they're a poor metabolizer, they may be barely metabolizing that drug, and maybe not through 2D6, but whatever the other cytochrome P450s are capable of doing. Now, we normally tend to think of this in terms of our regular drugs, but what happens if the drug is a prodrug? So what would happen if you put a patient who was a poor metabolizer on codeine, the prodrug? Would they be able to metabolize it to the active form? No. So that's how you might have a patient who's saying, this codeine isn't helping me, doc. They're not drug seeking, okay? They just actually can't metabolize it to the active form. And let's think about this more. When your pharmaceutical companies and your pharmacologists are actually doing the drug testing and they're coming up with this starting drug dose that you should be using, it's based on these people, our extensive metabolizers and our intermediate metabolizers. Okay? So we're trying to go with these. Now, is that reasonable? What I have here on the right is a pie chart, and what we're looking at are phenotype frequencies. And between our extensive metabolizers and our intermediate metabolizers, that's about 80% of the population. Okay? However, about 20% of the population is either an ultra-rapid or a poor. How many patients are you going to see today? Because what it means is that for every 5 patients you see, 4 are predictable, but 1 is not. I'm guessing that's going to add up pretty rapidly for you. Another way of looking at this, friends, is that when you start to look at whether somebody is a poor metabolizer, ultra-rapid metabolizer, or in between, it's going to say that for the same dose, some patients will respond as predicted. Some patients, this dose will not even be therapeutic for them. Other patients, it could be toxic, leading to adverse drug effects. All right. So, based on this, what do you think was the genetic diagnosis for Michael? He was star 5, yeah. So he was a poor metabolizer. He lacked any of the 2D6, okay? And that's actually what they had to do, is that his samples were sent off, and then he was genotyped, and they found out that he wasn't expressing it, okay, the 2D6. And so there were other things too, like for example, at autopsy, because you had an elevated ratio of the norfluoxetine, it wasn't consistent with mom and dad snapped, pinched his nose, and poured a bottle of Prozac down into him, right? And so there weren't pills in his stomach or anything else like that. But the reason that I tell this story is that this is what really helped make us change our thinking, particularly in pharmacogenetics and in the pharmacogenetics of psychiatry. Before this, everybody goes, oh, fluoxetine, SSRIs, they're safe. Well, for most people, they are, but clearly not everybody. So, all right, I've made a big deal. Genotype is linked to phenotype, but is it always? And when I do this little number, it means I got something. All right, so here's a study that came out a few years ago. And let me try to help walk you through this because I know it's not easy to see. What they did was they took 900 patients. Okay? They put them on venlafaxine, gave them a dose, waited a period of time, and then looked to see how much of the primary metabolite desvenlafaxine the patient had in their blood. And they determined the ratio of the metabolite to the parent compound, right? They also genotype these patients. And what you can see, I tried to box this off, is that one of the patients that, or should say, about 31 of the patients they looked at were ultra-rapid metabolizers, that they had that star 1 and star 1 NX. A lot of the patients were extensive metabolizers, the next box at the top. Then you had your intermediate metabolizers, and down at the bottom were your poor metabolizers. Okay. What am I trying to show you? When you looked at the ratio of your ultra-rapid metabolizers, you had about 5 times the amount of the metabolite. Okay? When you looked at the ratios in your extensive metabolizers, about double the amount of the metabolite. Your intermediate ones, about equal. But when you start to get down to your poor metabolizers, maybe on average about 1/10. Okay? So there's a big difference. All right, now that all makes sense, because when you sit there and they can look at the genotype and they can look at the ratios for this first set of patients, the genotype and the phenotype were linked. But that wasn't always the case. So what we're trying to show you in the next set of columns was that where the patients were taking a known inhibitor of 2D6, paroxetine is a known inhibitor of 2D6. Fluoxetine are known inhibitors of 2D6. And one of the things that you can start to see there, okay, like here I haven't light these all up. These patients who are on known inhibitors in red, okay, the amount of the ratio is about half. So these patients who, according to their genotype, okay, are extensive metabolizers, and they should have had a ratio of about twice the amount of the metabolite. Patients who were on a no inhibitor, their phenotype, instead of looking like an extensive, looked more like an intermediate, or maybe one almost starting to push down possibly into their poor metabolizers. This is phenotype-genotype discord, right? So here's a summary of it. Of those 900 patients, about 4% of them genotypically were poor metabolizers. About 27% of them, however, phenotypically, looking at those ratios, were poor metabolizers, which means, okay, 27, 4, about 23% of the patients had phenotypically converted to a different profile. Make sense? All right. So what this is translating to is that there were multiple factors that actually contributed to their phenoconversion, with a classic one being if you put the patient on a drug which inhibits the enzyme. But there could be other things that are going on contributing to it. So what does this mean to y'all? Okay. Does this mean that genetic testing is invalid? No. What it just means is that your genes are not always the 100% predictor of how you're going to respond. And if your patient is not responding the way you think they should genetically, maybe there's something else going on that you need to think about. All right, so let's move over to another category, idiosyncratic. Now, idiosyncratic is where something happens that you can't predict based on the mechanism of action of the drug, right? So like, for example, if you put a patient on furosemide, Lasix, okay, might you result in over-diuresing them, okay, hypovolemia? Sure, okay, but that's a predictable adverse effect. If you put a patient on an NSAID, they might start having some kidney issues, but again, that is predictable based on the mechanism of action of nonsteroidal anti-inflammatories, okay? The constipation that can happen with patients who are on opioids, again, all logical extensions. What becomes idiosyncratic, okay? Why do patients on cyclophosphamide have hirsutism, okay? But a big one is going to be rash for y'all. Have you ever worried about that, a patient developing rash, if they have Stevens-Johnson's? I mean, if they are put on lamotrigine? Yes, all right? So let's think about this. I actually like this cartoon a lot because it really describes, in order for Stevens-Johnson to actually happen, you have to have a bunch of contributing factors that all line up just right, okay? One is going to be associated with a specific drugs, okay? Allopurinol, carbamazepine, lamotrigine, and so forth. But other things, metabolism, okay, immunogenetic, T cell clonal types, and so forth. All this has to come together for the patient to actually develop Stevens-Johnson's. So, but let's take a look at this. Can you see a potential for a pharmacogenetic link here? Okay, if your patient isn't metabolizing their drug, okay, and the amount of drug in the body goes up, is that going to increase their likelihood of developing Stevens-Johnson's? Okay, but the big one, okay, and it's very well documented, is going to be their HLA alleles. So, human leukocyte antigens, okay. As you all know, you need your HLAs to help regulate your immune system, right? So they help to do things like they recognize like foreign proteins and so forth. Now here's the thing about your HLAs. There's lots of them. They're encoded on chromosome 6 and there is a lot of variation. It is very highly polymorphic, which means again, if we start to look through all of us, we probably have different ones. Okay. Of your HLA-B, hundreds of alleles. And why is this important to y'all? Because the alleles star 3101, and in particular 1501 and 5801, are very tightly associated with a patient developing Stevens-Johnson's when they are put on a drug that is known to precipitate it. So, and the prevalence of that particular allele depends in many cases on the ethnic background of the population. Here, what I'm trying to show you is that carbamazepine, lamotrigine, okay, phenytoin, drugs I'm sure you've worked with. Okay. If a patient has the HLA-B 1502, they are at significantly elevated risk of developing a rash or Stevens-Johnson's with it. The 1502 allele is much more highly prevalent in patients of Han Chinese ethnic background. All right. Now, so it's to the point that the Clinical Pharmacogenetics Implementation Consortium, okay, and since you'll have these access to these slides, I actually have the link to it so you can look it up, recommends genetic testing of patients of this ethnic group before you actually start them on this. The single drug that has the highest incidence of precipitating Stevens-Johnson syndrome, however, is allopurinol, okay, for gout. And what that is associated with is the B5801. 5801 has equal prevalence, almost completely equal prevalence regardless of the ethnic background. So anybody can particularly have it. All right. So here's the $64,000 question. Is it worth testing your patients? All right. Now, if you are in infectious disease, absolutely. Okay. If you are in hematology oncology, okay, testing the patient's cancers, absolutely for biomarkers, since so many more therapies are driven towards specific biomarkers. For y'all, okay, the end of the story is meh at this point. Okay, I'm never going to lie to you. Okay. All right. So let me explain why I came to that, very scientific sounding conclusion. Okay. Willing to bet all of y'all have gotten something where you've seen the companies trying to sell you this, okay? And there are a lot of them, and I really can't tell you anything about one group versus another, all right? But I've seen a lot of these. You can get testing done through different hospital laboratories and so forth. Now, what you need to understand in these tests, for the most part, they are panels. Okay, so it's not just I'm going to look at all of the different potential alleles for just 2D6 or just 2C19. It's some kind of combination of genes that have a loose connection, a correlation with psychiatric disease, again, like the serotonin 2A receptor, for example, serotonin reuptake transporter, and some different selection of the pharmacogenetic genes, okay? Like they may have some of the 2D6 alleles and not other, all right? And what they're trying to sell you on is that we're gonna make it easy, okay, for you, okay? The scientists are gonna sit there and do the genetic analysis for you and we're gonna send you a report, okay? So it's easy for you to work with. But, how do you really evaluate this? Okay? So for physicians who are doing like infectious disease and so forth, really what you need to know, and will apply to you, is how clinically valid is this? is it really going to be able to tightly predict patient response, right? So, like I told you about the cystic fibrosis, if the patient had the polymorphism in their CFTR gene where they had a G to E, trying to remember, switch, highly predictive, really, really good test, okay? Can it help to guide you towards more efficacious medicine? In the example I just gave you, absolutely. Okay, those patients are candidates for ivacaftor. Patients with the phenylalanine deletion are not. All right. Does the test reduce your healthcare expenditure? Sure. But again, in psychiatry, don't think we're really quite there yet. But I'll show you some examples where it looks like we might be going in the right way. So here's a paper that came out a couple of years ago. And I'm just using this as a way to try to point out things you should be looking for in some of these papers, all right? In this particular case, this was the neuropsych clinic in Raleigh. And what they did was they recruited patients, and all of their patients that came in took the short form of the neuropsychiatric test, okay? And then all of these patients took it, and then they looked at patients who had taken at least 4 of them and whether or not they had had genetic testing, okay? And from this, they found out over a period of a year, they had 131 patients who actually qualified for the study, 74 tested, 57 untested. So what they saw, first of all, is that the patients who had agreed to genetic testing had a higher disease burden based on the results of this survey. So when you're taking a look at the different dimensions, like anxiety, okay, the patients who underwent genetic testing had a score of 128. The patients who did not undergo genetic testing had a score of 93. And this really goes across the board, okay? Suicidal patients, patients who are having difficulty sleeping, many more of them. So what that was really telling us is that patients who had a more severe disease burden were more likely to undergo genetic testing, all right? Okay, that makes sense. But here's the thing. According to this group, when their psychiatrists utilized this information that they got from the test they used, and the test they used was the Sure Gene test, what they found was that here we're looking again at these parameters, and they treated the patient, and then they started to develop a slope of the curve, okay? Is the patient's disease burden going down? And then they extrapolated it out to a year. So they may have only collected the data for a couple of months, but then they extrapolate out how much further they think that their disease burden would have hopefully decreased, okay, after a year. That's an issue in and of itself. But according to their predictions, okay, what you saw is that patients who underwent the pharmacogenetic testing and had their therapy altered on the basis of it showed a greater improvement in their symptom burden. So like, for example, patients who were tested had a bigger decrease, minus 71, versus the patients who were untested, minus 14. So from this, the conclusion that they drew is that their tested patients, and they used this information to drive the therapy, had a better overall outcomes, okay? That's awesome, right? Just awesome, okay? But, always got a but, okay? And because, I can be cynical. All right. The lead author works for the test manufacturer. Yay! All right, so I'm kind of worried about that. The other thing that they do is they just looked at, the whole panel of tests. Did the entire panel improve? Not one specific test or another one. Maybe the things were just, maybe they're just a 2D6 poor metabolizer. Was it really necessary to look at all these other things? They were missing controls, okay? Age, gender, smoking, none of that was there. They just had, you were tested, you were not tested. And they tried to term this a naturalistic study, because this is really trying to represent the people that just walked in to this clinic in the Raleigh-Durham area. All right, so, it looks promising, but there's enough there, particularly with the top one, that I'm a little concerned. All right, other concerns that I have when you're starting to use genotyping. As of a few months ago, at this time, there's still no government agency that has regulatory product control over genetic testing. None. All right? So how well regulated these tests are and so forth, not seen. In terms of psychiatry, there's really only a few FDA-validated biomarkers. This is not like cancer, all right? So that's an issue. I've combed through the literature trying to look for psychiatry and pharmacogenetics. I got the biomedical library to help me, okay, because I'm not kidding myself. They're much better at finding papers than I am. And we could really only find a few, and most of those were published by the test manufacturer or had some kind of relationship with the test manufacturer. So again, all right, a lot of times those sizes are too small. 74 were tested, okay, whatever I said, 50 did not undergo the testing. That's still a pretty small number of patients. Many of these studies are just based at doing a single dose or 8 weeks. So we're really not looking at long term. And in psychiatry, that's really what you want to get to. Now, it may be, okay, I do see hope on the horizon. In this particular study, what we're trying to say is that they were looking at specific genes, like 2D6, 2C19, and that it really looked like in these patients that the testing was helping them. And this was a better controlled study that came out in Psychiatry Journal that did not have some of the concerns of the case report that I just presented to you. Other things, just to be aware, none of those panels currently are perfect, all right? They just aren't. So what you're going to see is that in this particular study that came out not too long ago, last year, they looked at a whole bunch of different test panels and did an analysis of them, okay? None of the panels that they looked at fulfilled all the recommendations for pharmacogenetic tests that are offered by the CDC or the clinical pharmacogenetics implementation. None of them met all of the recommendations, okay? None of them had all of the same combination of alleles. So one might look to see whether there's a star 5 allele, and the other one might look to see if there's a star 4 allele, but they may not be this on both panels. Make sense? All right. So you might get some information, but still might not have the entire picture that you need to draw a valid conclusion. All right, so I'm just going to finish off quickly with, the other thing you need to think about are the ethical issues of this, okay? Can all of your patients give informed consent, okay? What does this mean, okay, also for the family of the patient? So some of these disorders that you may be finding, okay, or some of these genes you may be looking for, okay, the family may also have it. So if you test a patient for Huntington's, do you think that patient's son or daughter may want to know? Might it impact them too? So this isn't like just let me determine how much of this drug is in your plasma, which just affects you. The results of these genetic tests have ramifications on the other family members. All right. The last thing I wanted to mention is direct-to-consumer testing. All right, you can't turn on the TV anymore without, or the internet without coming across some kind of direct-to-consumer testing. 23andMe, Ancestry, everything, right? Well, I have up here a paper that came out a few months ago. All your data belongs to us. Data practices among direct-to-consumer genetic testing. Yeah, it's theirs, okay? Now, what they did in this study is they found that most of the companies that are doing this had good security protocols, okay? So it's highly unlikely that Joe Hacker is going to be able to just hack in and get your genetic information, all right? But, again, always a but, they don't tend to tell you that your data is used for research and secondary, all right? So this is a potential problem. And you may have heard of things like that happening with like a little company called Cambridge Analytica, right? All right. So, final thing that I wanted to mention, and I'm sure all of you are familiar with the Genetic Information Non-Disclosure Act of 2008. This is one of the final pieces of legislation that George Bush signed before he left office. This was landmark, my friends, because before this particular documentation, you could be fired on the basis of your genetic testing, right? Even if you didn't show any symptoms. If you had a genetic test that said that it looked like you were going to develop Huntington's, it doesn't matter if you're 25 years old and perfectly healthy, you could be fired for it at that time. All right. Now, so what did this do? It set federal minimum standards. It did not weaken any state laws for protection of an individual's genetic information. But, so it made a big thing. What it really did is it prevented discrimination in employment and health insurance, okay? So your insurance, your Blue Cross could not drop you just because your genetic test said that you might develop, Alzheimer's later in life. Cool? But it did not grant you personal control over your genetic testing results, okay? It did not cover life, disability, or long-term care. So if you have genetic testing that shows that you may develop a genetic disease later in life, life insurance companies do not have to cover you, okay? So what that means is that when you start to talk to your patients about having genetic testing, you've got to keep this in mind, all right? Because it may impact other things in their lives. And I don't know what happened here, but I just found this. A bill was introduced a few months ago that allows employers the right to demand your genetic tests. Ooh. And I don't know where that is right now, okay? If y'all find out, please let me know. Okay, so a few things, and since you have access to these slides, a lot of my information came from the Pharmacogenetics knowledge base. You want to know something about a gene linked to a drug? This is the place to go. In great, great detail, they will tell you this, okay? If you want to help look for some guidelines, okay? What should I test my patient on? I want to put them on a specific drug. The Clinical Pharmacogenetics Implementation Consortium has specific guidelines for specific drugs. So a very, very useful source. The FDA actually has validated biomarkers, so you can look up the ones that are actually specifically validated for psychiatry. All right, so really, what I'm starting to see here for psychiatry is that pharmacogenetics are increasing in importance. And the more we understand about how the human body works and the actual pathology going on in psychiatric diseases, I think the more important it will become for you. Okay? A lot of these genes, however, that you're starting to see may not be actually validated as a biomarker. Okay? So in many cases, genetic testing is not recommended except with the ones where I tell you specifically, right? Like your HLA 1502. Cool? All right. Take a look at those guidelines that I gave you. They can help you decide whether or not you should recommend genetic testing for your patients. Okay? And what you're going to see when you actually go into the CPIC guidelines, they actually list recommendations for a lot of the drugs that y'all are using right now in psychiatry. Okay. If you're going to put a patient on carbamazepine and they're of Asian ancestry, test them. Test them for sure. Don't hesitate. Test them. Okay? And finally, I guess one of the big things is an idea of potentially future collaborations. Okay? It may be that what we need really are more studies. Will this help the patients? So we have basic scientists here at Quillen that can actually do basic science research, okay, to help try to look to see whether there is an association. Many of the laboratories that I work with can do basic research. They are not licensed for doing clinical. So you can't do a genetic test like in my core facility and use that to direct patient care. But if you wanted to do a research study, then we can do that. We were actually doing a project with infectious disease right now. All right. So that is basically what I had to say. And friends, again, thank you so much for taking the time out to come and listen to me. I'm really delighted to be here. I hope that you found it beneficial, and I have happy to answer questions. Okay. Yeah.
I just wanted to say I really appreciate your giving the full picture.
Oh, well, thank you.
Because I've actually used it on judiciously. So your examples, I had a patient with amphetamines that when she was needing a higher doses, very reliable, whatever. She was willing to pay. The insurance wouldn't give her more than a certain amount per month.
Right.
And she was willing to pay for 2 prescriptions. I just didn't agree with that she has to pay 2 copays.
Right.
So I just did testing. She was very rapid metabolism, rapid metabolism.
Yeah.
And so based on that, they allowed her to get the higher dose. So I think in circumstances where it doesn't fit the picture, it is not the typical, that's where I think it makes sense.
That makes sense to me.
I'm so glad that you shared that that's the case, and with all of the push that the companies are doing, saying it's the be-all and the end-all, you know. And I'm glad you pointed out the drug company sponsored people are there. There was in Psychiatric news a recent, I just read yesterday, about esketamine and how it's the next great thing, but then you look at it and the people that written the article, you know, are the people that work for the Johnson company and things like that.
Of course.
And there are definitely
Yeah.
some areas that it
Yeah.
actually can be esketamine. This particular one had to do with nasal for in the inpatient, whatever short thing. But I think it's important that people look at what the studies are saying, as you say, the onward prediction
Right.
based on a short period of time. It does not mean the slope's going to continue that way.
Right,
It may,
exactly.
you know, yeah. So I really appreciate that you gave such a wonderful way of
Oh,
looking at
thank
all
you.
perspectives of it.
Thank you. Well, and one thing always to take home is always be a little critical of the literature. And one of the first things, particularly in psychiatric literature, I'm always looking for that conflict of interest. So one of the things that's always difficult to find is who funded the study. And that's crucial because studies have shown when you do, I've seen like giant meta-analyses where it might look that one particular drug actually helps the patient based on 100 studies or so. When you take out the studies that were funded by the drug company, the efficacy of that particular drug went away. So you just need to take all of that into consideration. Okay. Yes, sir.
We have a high prevalence of smokers in our population.
Right.
So if you do a test on like 1A2, which is highly inducible by tobacco smoke,
Right.
is that going to be reflected on these tests? Or does
Okay,
it
the
depend on
genetic
test?
test is just going to tell you the
But
genetics.
phenotypically,
So it's not going to tell you the phenotype. So what you might want to do
so you still
is,
have to take that into consideration.
right. So, I mean, what you're kind of looking at is something almost acute versus long-term. So the genetics is trying to tell you like a big overall picture, but like an actual plasma drug level helps to tell you what's really going on right now. And in many cases, okay, particularly non-smokers or somebody who's not on concomitant medications, it's going to be more highly predictive. But yeah, if you've got a patient who's like a heavy smoker, and particularly in psychiatry, right, I would definitely also want to do like plasma blood levels. Okay. So, yes, sir.
One of our issues in psychiatry these days is we see more patients with medical illnesses probably than ever before. In my case, I'm interested in HIV,
Okay.
which you brought up in your talk, and about 50% of those patients have neurocognitive disorders, somewhat lower percentage have depressive spectrum disorders,
All right.
which is really of relevance here because they're given the protease inhibitors, which inhibit 3A4.
Yeah.
On which the benzodiazepines are metabolized.
Yeah.
And to a lesser extent, those same drugs inhibit 2D6, which you already mentioned,
Right.
are where the antidepressants and antipsychotics are metabolized.
Right.
So I think that's a very important issue in certain areas of psychiatry.
Oh, definitely.
Also, another example is a particularly neurotoxic antiretroviral efavirenz. There is a polymorphism for which, if you're homozygous, you will have a very high level. And so that's another
Right. concern
because it's been associated with suicidality with efavirenz.
And there's actually a study looking at efavirenz here at Quillen with John Mormon's group. And so, yeah, I can understand it. For patients that are on so much polypharmacy, a lot of times drug interaction software like Lexi Interact or whatever your personal favorite would be one of my friends that I would want to be reaching for.
But my bigger point
Yeah.
is really that for psychiatry isn't really the way we should be thinking. We should be thinking
yeah.
for the patient and all of the
Excellent.
medications the patient is on,
Yeah.
including psychotropics.
Absolutely. Okay. Oh, hey.
You mentioned evaluating genetic testing beneficial. So I was studying about Cosrol, and they were talking about using like HLA-DQB1 like as a marker to see if they're more susceptible to agranulocytosis. Even though 1% of the population is only susceptible.
Right.
So do you think in the future it'd be helpful to add like a criteria to determine the beneficial versus the?
That's actually one of the things that the CPIC actually looks at, is they do an analysis and reviews of all of the literature to help develop their guidelines. So I think that the more guidelines that we can, that's done by people who really know the literature, would be very beneficial for people. And yeah, and I would definitely look up the CPIC. Okay? Yes, Dr. Miller.
So I thought your presentation was wonderful as
Oh,
well.
thank you.
And really appreciate the wide review of all the different issues. So when you mentioned that these genetic testing things like the 23andMe are available potentially and could affect somebody's ability to get life insurance and long-term care, how likely is it that that would be accessed by these companies? How would they ever know that patients have?
Okay, at this time, okay, GINA is still in effect, right? So a company cannot demand the results now. But I don't know what's going to happen to that law, since at least as of last December, November or December, they were thinking about overturning it and letting people demand the results of your genetic tests. So at this point, I think you're still protected, but I don't know what's going to happen in the future, unfortunately. And I'm not, very up to date on all the aspects of medical jurisprudence. So other ways that they could get it would just, there's nothing that can't be gotten around on social media, right? If somebody posted up on Facebook that I just got this back and it looks, and I'm scared because I'm going to have Huntington's, and one of their friends from work or their boss is on it, and they can find out through that route too, in which case, because you made it public domain. So I really don't know how to answer your question, Mary, but it's something that unless we have strong protection of, I could see the potential of it going away. Okay. All right. Anybody else? All right. Friends, thank you all so much.